Healthy Insurance in United States Part 2. History. See also. History of insurance accidents. Insurance was first offered in the United States by the Franklin Health Associates Company. This firm, founded in 1850, offered insurance against injury, railroad and steamboat accidents. 60 organizations were offering accident insurance in the USA by 1860, but the industry consolidated rapidly soon. There, while there were earlier experiments, sickness coverage in US effectively dates from 1890. The first employed secondary group disability policy was issued in 1911, but this plan primary purpose was replacing plan's primary purpose was replacing wages lost because the worker was unable to work, not medical expense. Before the development of medical expense insurance, patients were expected to pay all other health care costs out of their own pockets under what is known as the free for service business model. During the middle to late 20th century, traditional disability insurance evolved into modern health insurance programs. Today, most comprehensive private health insurance programs cover the cost of routine, preventive, and emergency health care products and almost prescriptions drugs, but this was not always the case. The rise of private insurance was accompanied by the gradual expansion of public insurance programs for those who could not acquire coverage through the market. Hospital and medical expense policies were introduced during the first half of 20th century. During the 1920th century, individual hospitals began offering service to individuals on a per paid basis, eventually leading to the development of Blue Cross organization in the 1930s. The first employer-sponsored hospitalization plan was created by the teacher in Dallas, Texas in 1929. Because the plan only covered members' expense at a single hospital, it is also the forerunner of today health maintenance organization HMOs. In 1935, the decision was made by the Ross Steve administration not to include a large-scale health insurance program as part of the new social society program. The problem was not attacked by any organized opposition, such as the opposition from the American Medical Association, the Dalit Trump's proposal in 1949. Instead, there was a lack of active popular congressional or instant group support. Resolved strategy was to wait for a demand and a program to materialize, and then if popular enough to throw his support behind it. His Committee on Economic Society CES deliberately limit the health segment of social security to the expansion of medical care and facilities. It considered unemployment insurance to be the major priority. Resolved assured the medical community that medicine would be kept out of politics. Jeb Koijaman says he succeeded in pacifying the opponents without discarding the reforms. The right moment never came for him to reintroduce The topic: the rise of employer-sponsored coverage. Employer-sponsored health insurance plans dramatically expanded as a direct result of wage controls imposed by the federal government during World War II. The labor market was tight because of the increased demand for goods and decreased supply of working during the war. Federally impressed wage and price controls prohibited manufacturers and offer employers from rising wages enough to attack workers. When the World Labour Board declared that fringe benefits, such as sick leave and health insurance, did not count as wages for the purpose of wage controls, employers responded with significantly increased offer of free benefits, especially health care coverage to attack workers. The tax dedu- the tax deduction was later codified in the Revenue Act of 1954. President Harris Trump proposed a system to public health insurance in this November 1945 address. He envisioned a national system that would be open to all Americans, but would remain optional. Participants would pay monthly fees into the plan, which would cover the cost of any and all medical expense that arose in a time of need. The government would pay the cost of services rendered by any doctor who chose to join the program. In addition, the insurance plan would give cash to policy holder to replace wages lost because of illness or injury. The proposal was quite popular with the public, but it was frequently opposed by the Chamber of Commerce, the American Hospital Association, and the AMA, which denounced in it was socialism. Foreseeing a long and costly flight better, many labor unions choose a campaign for employers sponsored coverage, which they saw as a less desirable but more achievable goal. And a coverage expanded, the national insurance system lost political momentum and ultimately failed to pass. Using healthcare and other fringe benefits to attack the best employees, private sector with collar employers nationwide expanded the US healthcare system. Public sector employers followed suit in an effort to compete. Between 1940 and 1960, the total number of people enrolled in health insurance plans from sevenfold from 2 crore to 142 crore, and by 1958 70% Americans had some from to health coverage. Mills Act. Still, private insurance remained unaffordable or simply unavailable to many, including the poor, the unemployed, and the elderly. Before 1965, only half of seniors and health care coverage, and they paid 3 times as much as younger adults while having lower incomes. Consequently, interest persists in creating public health insurance for those left out of the private marketplace. The 1960 Criminals Act provided matching funds to states assisting patients with their medical bills. In the early 1960s, Congress rejected a plan to subsidize private coverage for people with social security and unworkable, and an an amendment to the Social Security Act creating a publicity run alternative was proposed. Finally, President Lyndon B. Johnson signed the Medicare and Medicaid programs into law in 1965, creating publicity-run insurance for the elderly and the poor. Medicare was the later expanded to cover people with disabilities and stage renal disease and ALS. State risk pools. Prior to the Patient Protection and Affordable Care Act, effective from 2014, about 34 states offer guaranteed issuance risk pools, which enable individuals who are medically insurable through private health insurance to purchase a state-sponsored health insurance plan, usually at high cost with high deductibles and possibility lifetime maximums. Plans varied greatly from state to state, both in their cost and benefits to consumers and in their methods of founding and operations. The first such plan was implemented in 1976. Efforts to pass a national pool were unsuccessful for many years. With a patient's protection and affordable care act, it became easier for people with pre-existing conditions to afford regular insurance. Since all insurance are fully prohibited from discriminating against or charging higher rates for any individual based on pre-existing medical conditions. Therefore, most of the state-based pools shut down as of 27. Some remain due to status which have not been updated, but they are also may cover people with gaps in coverage such as undocumented immigrant or medical eligible individuals under the age of 65.